This presentation, titled Peri-implantitis, Diagnosis, Prevention, and Treatment, is intended for the general practitioner, dental students, dental hygienist assistants, and the general public. I'm going to try to be as brief as possible because it is just an overview about peri-implantitis rather than an in-depth, detailed presentation. The peri-implantitis definition, the latest definition that is that it is the inflammation in the peri-implant soft tissue and progressive bone loss. These are the two criteria, and these are the three individual criteria that it should have progressive bone loss of greater than or equal to 3 millimeters. It should have deep pockets greater than or equal to 6 millimeters and bleeding on probing. Now, this 3 millimeter mark is actually, according to Berglund, if we do not have initial radiographs from the time of placement of the implant. Otherwise, if we do, then it is 2 millimeters bone loss or greater would be considered peri-implantitis if it's accompanied by deep pockets and bleeding on probing. Peri-implantitis has a prevalence of 22% according to the 2015 study, and its main etiology is considered to be plaque. However, we know that it's multifactorial as well, meaning infection during implant placement or overload on the implant if it is not centralized with the load, with the vertical load, and if there's a fracture, then it collects plaque, and some other factors might be involved, all culminating to the plaque accumulation, which is the main etiology of peri-implantitis. Its prevalence is higher at the patient level versus the implant level, meaning some patients are more prone to get peri-implantitis than others, especially if they have a history of periodontitis, for example. So, which brings us to the risk factors and risk indicators of having peri-implantitis. We know smokers have a higher risk, and I believe it's 2 times or 3 times the non-smoker risk of getting peri-implantitis. So if you have a history of periodontitis, which is gum disease, this can also is considered a risk factor for having peri-implantitis. So you have to take extra measures to take care of your implant. Furthermore, lack of regular maintenance or poor oral hygiene is another risk factor for having peri-implantitis, so we have to consider that as well. Peri-implant mucositis has a high prevalence of 63% according to the latest systematic reviews, and it is basically a reversible inflammation of only the soft tissue and not bone loss. There's no ongoing bone loss around the implant. Okay, so what is inflammation of the soft tissue? Well, it is gingival erythema, maybe some bleeding on probing or suppuration, deep pockets possibly. It is considered a precursor of peri-implantitis, meaning if you do not take care of the mucositis, which should be reversible, and you let it sit, then it becomes peri-implantitis. So all peri-implantitis was preceded by mucositis. Its main etiology is plaque accumulation. Our treatment goal for treating mucositis is basically to reduce the bacterial load, therefore improving cleanability of this area of this implant. We want to achieve pocket depths less than 5 millimeters, not 4 like natural teeth. And we do not want bleeding or suppuration, and we do not obviously want ongoing bone loss. The treatment consists of debridement, and some other authors have added other antimicrobials that may assist. However, the main factor in treatment is debridement. This is an example over here of a patient I've seen where some excess cement was left rather than removed at the time of crown cementation over the implant abutment. Cement can hardly be seen in radiographs, however, you can see some indicators like this, for example, and these are the particles of cement that were cleaned off with a curette after anesthetizing this patient. This patient, we had noticed deep pocketing, but no bone loss yet. Bone loss would have happened eventually if the deep pockets were not taken care of and if the cement was not removed. This is another reason of having mucositis, deep pockets around this implant but no bone loss, because of the crown contour being way over contoured here, as you can appreciate in this radiograph. This corner over here, it should have been concave, and we'll have another slide showing the difference between a convex, such as this slide here, versus a concave crown contour. Unfortunately, due to this over-contoured crown, the neighboring tooth got a vertical defect, as we can appreciate here in this radiograph. This crown needs to be removed and replaced with another under-contoured crown. And this is the crown contour according to Catafucci 2018. They did a study where the convex crown contour was considered unfavorable, while the concave crown contour is considered favorable because it leads to less plaque accumulation and thus less mucositis and less implantitis. In this slide, we can appreciate also that a crown margin so close to the bone leads to a higher plaque accumulation level. Now, fortunately, this patient did not have ongoing bone loss. There is no bone loss appreciated yet. However, it will eventually become peri-implantitis. As of now, it is considered mucositis because we only have deep pockets with suppuration and bleeding on probing. We can also appreciate open crown margins here. Crowns need to be redone in this case. Now, let's say we already have peri-implantitis, we have bone loss. How do we measure the bone loss? I typically measure the deepest area where there is bone loss. Rather than here, I'd measure it from here. I'll measure it as well from the implant abutment interface. This is the level where the implant was inserted typically into the bone. So the bone used to be at this level, or the red line here, and it was lost all the way up to here. Okay. Moving on, sometimes it gets to be difficult to appreciate where the bone loss is. A lot of times the bone loss happens circumferentially around the implant. Therefore, it is considered up to here, and now we need to know how many millimeters. Is it 2 millimeters, 3 millimeters? Because this will determine what kind of treatment needs to be performed. And this is a little trick that I do on the radiograph. On the digital radiograph, I mark here with this line where the implant abutment interface is, and this is the A line here. This is the implant length according to what my digital radiograph suggests, and this is where the bone to implant contact is. This is the most coronal bone to implant contact that I can see and appreciate in this radiograph. And on this implant, it reaches all the way to here. If you can see, there's the faint radiolucent line that ends right over here. And this is how I measure the length. Now, let's say your radiograph is not calibrated and your radiograph digital system did not determine the length here of if it's 2 millimeters, 2.5 to 3 millimeters or so. What we can do is identify the length of the implant first, and therefore by a simple calculation we can identify the amount of bone loss that is present. And a little trick to that is through this implant, this website over here, whatimplantistat.com, where you can just through their drop down menus you can identify which implant system it is if you do not already know which implant system. And therefore, let's say this previous implant was a Zimmer TSVT, and therefore you can count the number of threads on this particular implant that you have at hand, and oh, it's 13 millimeters. So you go back and you can identify that this 13 millimeter implant is the entire length, and by ratios you can find the amount of bone loss happening. Let's say you already have peri-implantitis. In this case, you have greater than 3 millimeters of bone loss accompanied by deep pockets and bleeding on probing. What do you do? Well, the treatment goals are simple. We want to reduce the bacterial load that's present. and we want to improve cleanability, okay, as we mentioned earlier, reducing the pocket depth, no bleeding and probing, no bone loss. Now, pocket depth is 5 millimeters here, but it's not a solid number because each crown and each implant is different. Some difference happens dependent on the height of the soft tissue. Now, what treatment approach is there for peri-implantitis? Unfortunately, it's only surgical. We start with non-surgical therapy, which is just cleaning around it at the dental office using curettes, but it's ineffective. It just reduces the amount of inflammation to work with during surgery. Our surgery is either pocket reduction surgery, such as the pocket reduction surgery done around periodontitis, natural teeth, or regenerative approach, which means we either add bone or add soft tissue. It is really important after the surgery for maintenance to be performed every 6 months in non-susceptible individuals, meaning the individuals who are not smokers or don't have periodontitis. Otherwise, we'll have to do maintenance every 3 months for that population. The prognosis has proven to be good in the long term. Long-term survival was appreciated 69 to 98% of the time over the 7 years after surgery has been performed on peri-implantitis, if maintenance was continuous. Now, this is a case where it is it's not very common, where the implant unfortunately was placed inadequately. This is a Straumann S, which is standard. It has a polished collar, which is not meant to be in the bone. This implant system is meant to protrude all the way to the gingival level. As we can appreciate here in this radiograph, bone loss had happened around this implant and that implant, and we can appreciate it all the way to this level here. This implant should have been not placed at the bone level, therefore no attachment of bone, no osseointegration of bone happened to the coronal 3 millimeters of this implant, leading to bacterial accumulation and bone loss. And this is the level where the bone should have been during implant placement. Unfortunately, it was placed deeper than necessary by someone, and this is the implant system that was identified through the radiograph. It has a polished collar of 3 millimeters, and this is the bone level as the manufacturer, which is Straumann, recommends, which was not followed in this particular case. And what was performed on this patient was pocket reduction surgery, which involved apically positioning the flap and osteoplasty, meaning we created recession. In this after photo, we can appreciate the recession that we created intentionally, so we can have the implant more cleanable in the coronal aspect of this crown. Another case is due to excess cement that created this defect, as you can see distally here on this implant. This bone defect is a vertical defect due to this excess cement that was left in place and not cleaned appropriately. After cleaning this vertical defect and degranulating this, bone grafting was performed and followed by coverage, which led to healing of this bone vertical defect. Now, this is another case where implant fracture happened. Unfortunately, it was too difficult to identify this fracture when the crown got loose. The crown got loose, the patient noticed, he went back to the dentist retightened the screw in the center of the implant without noticing this little fracture here. It was very, very difficult to notice. This fracture persisted even though the implant was stable and solid again and not loose, but because of this fracture which persisted, it collected plaque and led to this bone loss. As you can see here, after flap reflection, we can appreciate the fracture here in the center of the buccal view. Plaque remained, leading to this defect all around the implant. Explantation needed to be performed and a new implant placed. Now, let's try to prevent implants from getting a problem. In this particular situation, soft tissue grafting was performed because the implant was referred to the periodontist, to me, because it had deep pockets. Therefore, we diagnosed it with peri-implant mucositis because there was no bone loss yet. As we can appreciate in this photograph, the before photograph here, we can appreciate that there is hardly any band of keratinized gingiva around the implant, while on the right side here, the after photo, after the surgery, after the graft, there is an adequate band of keratinized soft tissue leading to a more favorable situation for plaque removal. Patient was able to brush better there because the tissues were adapted firmly around the implant abutment. Sometimes we can appreciate right before we place the crown, while the healing abutment is still present, we can perform a surgery and perform a free gingival graft around it if we can see a very elastic and open sulcus around the healing abutment. We can appreciate 2 weeks after surgery already that it is more adapted and firmly attached to the healing abutment. Therefore, the crown will probably be more adapted and less pocket depth will be appreciated in the future. In this particular situation, the patient was missing an maxillary lateral. Before the implant placement, we can appreciate a little dip here in the occlusal view of the soft tissue and the bone. Now, when we placed the implant, there was adequate bone, which is 2 millimeters. However, there was inadequate soft tissue, so we attempted to thicken the soft tissue profile there by placing this material here, FibroGuide. We can place it to plump up the soft tissue horizontally. Okay, this is the post-op, immediate post-op after the temporary provisional crown was placed, and this is the before we start, and then after we start we can appreciate the thickened contour here of the soft tissue, which helps prevent the pocketing and recession in that location. Gingival recession sometimes happens if the tissue is very soft. The soft tissue is very thin, and therefore a gray shadow might be visible. In addition, bone loss might happen. This is an immediate implant that we placed and provisionalized. This root was remained after a fracture happened. The patient presented with adequate amount of keratinized gingiva. We removed the tooth root and we found enough bone to support the implant and make it stable. We placed the implant and we managed to place a provisional at the same day using a prefabricated crown that was filled with composite. We had to make a concave neck to reduce the bacterial load because a concave neck means a very thin neck. Thin neck means less plaque accumulates there, and the patient is able to keep this area healthy. And this is a radiograph immediately after placement of the implant, and this is a photo immediately after placement of the provisional crown. Now, this is another case where the patient had a root resorption around this tooth, number 8. We extracted the tooth, placed the implant. However, it was not tight or firm enough to place a temporary crown there. Therefore, a soft tissue seal was performed to preserve the amount and volume of soft tissue, especially in the papilla and this aesthetic region. We harvested a free gingival graft from the tuberosity region. We grafted it over the bone graft and implant that was placed, and this preserved the soft tissue height eventually. This is a 3-month post-op, and we can appreciate how the soft tissue here is preserved and the papilla is preserved. I don't have, unfortunately, a final photo yet. The conclusion after this presentation is that peri-implantitis is a common complication and should be relayed to the patients before placement of the implant so they can anticipate it and prevent it. Surgery is the only treatment option, and strategies of prevention are to be taken into consideration. These are my references, and thank you for listening.